So I'm just going to go show you one case, and in that case, there were 2 or 3 different areas where there was potential vascular complication, what I did to avert it. So it's always important to look at the CT. This is a patient, female, and you can see that the perimeter was 69. Minimum maximum measurements are given already, but essentially it's a patient who needed a 26 valve. Calcium distribution is the next thing to look for. Not too much calcium at the annular level. It's always important when you look at the CT, just have a rough idea what the overall architecture looks like. And it doesn't look too, at least looking at it does not look too challenging until you go down to the detail. And that's why it's important. So for those of you using CT, please, 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 of course, listen to the radiologist or whoever else is analyzing it for you, but learn how to do it yourself and really scroll up and down the anatomy to understand it very well. Now, also when you're doing the CT, CT I think has totally changed what we do in TAVI today. It's important to look at what slices the radiologists use to take your images. So, usually for the peripheral artery, you want it to be no more than 1 or 1.5 millimeters. You can occasionally see people do 3 millimeters, 4 millimeters, 5 millimeters cuts. That's fine if the artery look completely normal, but you can very easily miss significant focal stenosis if the cuts are too large. Now, if you look at this patient, there are clear evidence of calcification that's encroaching into the lumen. And certainly on the right side, there were areas where the calcification is quite significant. But what concerned me more was during like the puncture, and just above it, there was a lot of calcification that looked a bit hostile, less so on the left side. And then if you look at it in more detail and open it up, and you can see the puncture zone here where the arrow is here, there's a lot of calcification called hostile encroaching into the puncture zone. So the benefit of this, the system I'm using is three-dimensional. You can overlap what it looked like angiographically to what the CT would show. And what I would like to angiography is puncture somewhere there. And there's really very little area for me to puncture safely. So I looked at the left side, and again, clearly there are calcification, but there was a nice zone, probably about 5 millimeters area where I could safely puncture and be very careful, just proximal to the area, which again, you can then get fluoroscopic landmarks to know where that would be on the puncture time. So the plan then was to go transfemoral TAVI under local anesthesia. All our patients are fully awake and conscious. We're going to use an Evolut R and not a Evolut Pro because it has the lowest profile device for the valve size commercially today. I'm going to plan to insert a 14 French sheet to test the vessel access. And then I'm going to advance the valve just using the inline sheet, which is sheetless without putting anything else. Because I did not want to do multiple exchanges to minimize the sheath and then the delivery system back to the sheath again, I'm just going to do it without pre-dilatation. So here's the case again. So we've seen how there are many ways of puncturing the femoral artery. I agree with both Peter, Sai, and Susheel that ultrasound guidance now is very safe, minimize radiation to you. But what I wanted to show you here is when I used the ultrasound, the artery was so mobile that I wasn't happy doing that. So I'm good at both. So I use fluoroscopy guidance here, and because the aim is to puncture anteriorly and in the middle of the vessel. And even here, you can see how much during systoles and diastole, the artery just moves left and right and left and right. And that's important to remember. You want to puncture middle and anterior. And the other thing then to remember is when you're advancing the wire after the puncture, just look at what the wire itself is doing. You can see the wire naturally wants to push against the right ostia, the iliac, and then there's a little calcific area. So be very careful then when you're advancing wires. You can easily flick off a plaque and cause a dissection in the bifurcating area. And if you have a bifurcation problem, is exceedingly difficult to fix. If you can fix lower aorta, you can fix proximal iliac, but if you have a bifurcating tear or rupture, it's usually game over until the surgeon goes and tries to fix it. So I am a ProStar person. I like the ProStar device. It, of course, is technically a bit more challenging, but it never fails in heavily calcified anatomies. You need to know the steps. And if you know the steps, in the last 1 year, 110 cases where I first operated, I had one patient who needed surgical correction. And it's not that I'm good. It's because there are steps. You follow the steps, and then you get good results with it. Once a ProStar, so you can see that everything I do, I'm not doing this for the sake of this talk. Everything I do, I fluoro. And the reason for that is this. So once the Procedural goes in, you obviously need a stiff wire to advance your sheath. And you can see that in this case, I'm using a longicus wire, and you already can see that the wire is behaving as you predict in calcific anatomies. And I think by doing it in the fluor and not blindly, you're not going to push things blindly and cause dissections. And then next now I'm advancing a 14 French sheath. That actually goes reasonably safely. I mean, and you can see what I'm doing now. I'm twisting, and I'm twisting clockwise, anti-clockwise, not 360 turns, but just 20 degrees clockwise turning. And that's why you see the motions there. The motions are in me turning the sheet clockwise, anti-clockwise, but 30 degrees each side as I'm advancing it. Once I do it, then you cross the valve as standard. And again, another important thing, again, vascular complication is just not your femoral artery, it's the aorta, it's the left ventricle, and all of this can cause from getting a good result to a catastrophic result. Always, I think once you've crossed the valve, exchange it to a pigtail. And then once you've done that, before you put a stiff wire in the left ventricle, and in this case, the Medtronic valve, make sure the valve is loaded. Once you're confident the valve is loaded, because if it is a misload, it's another 10 to 15 minutes to reload the valve. And you don't want a stiff traumatic wire sitting in the left ventricle waiting for the valve to be loaded. Valve is checked, then you put a stiff wire in the LV cavity, usually a pre-shaped wire or shaped yourself, but pre-shaped I think are safer for those who can't shape it very well. And then here's the valve. Now it's important for us to pay the key thing is do it in a high fluoro setting, so you see all what the calcium is doing when you're advancing the device. I'm planning to go sheathless. It goes really well, and then it gets stuck just at this point. And it just will not go. That's me trying to jig it. Jig it is a very Northern Ireland statement. It means you're trying to, almost like a vibration effect, or the other analogy I gave is like a salmon trying to swim up against the current. You're jigging it a little bit, and you're just essentially moving the delivery system left and right very rigorously, but not twisting it too much. And it just does not want to go. It goes a little bit. You can see that the inline sheath is already separated from the capsule. That's fine because the patient was quite short. Half of it, a bit like what Sai shows, half of it is in the patient, the other half is in the outside, and it just does not go. I twist and turn 10, 15 degrees, just does not go. And this is now, I think is a composite of the anatomy, a composite of the calcification. Here's a little trick you can do. So at this point now, I gently unsheath the delivery system. So I'm releasing the nose cone. And as I'm releasing it, I'm advancing the delivery system forward as well. And by doing that, I'm gaining a bit like a rock climber. I'm gaining 2-3 millimeters forward. You can see that happening there. So by releasing the nose cone, by letting go the unsheathing the delivery system, the nose cone is clearly more flexible when it's released a little bit, allows you then to jump past the calcium stopping, but make sure that you do not release past a point where the nose cone is free. Then you could have kinking and you may not be able to resheath again. Can you see that? Just this point, it unsheaths, you can see the nose cone being delivered, then the valve moves forward. Now at this point, remember to resheath and not to go forward anymore. Then you can keep doing that until you go to a safe zone. I was able to go very nicely. And I thought, okay, home dry. And then it gets stuck in the thoracic aorta. Again, on the CT, I didn't show it on the CT again, there was an area of calcification just invaginating into the aortic lumen. Try different techniques, come back usually. Now here's a little tip. When the valve is loaded at 0 to 4 degrees. So the whole delivery system and capsule is stiff. Pull it back sometime, give it 10, 15 seconds to warm up. When it warms up, the whole thing could get more softer. And when you advance again, you may think it's your skill. It probably is your skill, but sometimes it goes very nicely past the area you're trying to go. If that goes, great. In this case, it just does not go. So then we tried what we've already mentioned before, clockwise, anti-clockwise turning 10, 15 degrees, not more than that, because you don't want the whole system to loop around. Still doesn't go. Always check to make sure there's no kinking in the delivery system before doing any more. Still doesn't go. Then what we did was to get the pigtail back, the contralateral pigtail for angiogram, back to where you want it to be. Then put a stiff wire. In this case, we put a lundicus wire. And that straightened that angled area. Leave the lundicus still in position because you knew that you can see the calcium here on the arch itself. leave the Lundquist wire in there to try to straighten the aorta a little bit, advance the delivery system all the way to where you want to go. And then you are where you want to be. Now, because this talk is really on access, I'm going to skip the next few slides because we can talk about valve positioning on the next session of positioning. But I think what I'm going to show is I'm going to skip all this and go to this point. Yeah, okay. So on removal of the delivery system, because of the very short ascending aorta and the angulated aorta, the nose cone was, we had impossible to get it out of the outflow portion of the frame. Tried many ways. One is to actually advance the wire in and try to deliver it. It still does not go. So then the other trick you can do now is to use, you can see that, and different wires, different angles is just getting caught in it. And if you pull this out really quickly, you could have easily pulled this valve out. So in TAVI, everything is slow, considered under visualization. So then what I did was to advance the system forward a little bit to pull it up, and then to resheath the device while keeping the nose cone where it is. So you advance forward and resheath it, and as it's resheathing, you allow then for the capsule to override the valve, nose cone valve, and then you can safely remove everything. And then I'm just going to go, let me skip that. So removing the sheath, what we routinely do in our unit is to put a crossover from the other side and leave a multi-purpose catheter, 6 French, on the large wire access. If I'm really concerned, what I tend to then do is to leave the wire where it is, let the wire go through the big sheath, cross clamp it so the wire is fixed. Then I tend to take either a 6 French guide or a 6 French long sheath and leave it parked there in the mid part of the iliac. That allows you then safely to take any balloon you want to occlude the artery or any stent you want to deliver if there's a massive leak. And then in this case, the ProStar is as predictable. I had no sheath. As you can see, I think on flow through, there's a small dissected plane there. But on ultrasound, that was a dissected plane with no luminal issue, no leak. So we left it. Most of these healed themselves. So then to conclude, I think it's really, really important. We've mentioned, all of us have mentioned, is to review your CT, look at it yourself. Don't just listen to what the radiologists tell you. And then I think Andrea's right. Look also at the angiogram carefully. And what you're looking for on the CT mainly is angulation, calcification. But on the angiogram, what you will see is mobility, stiffness, or the vessel compliance. If the vessel does not seem to expand and dilate during, expand and contract during systole diastole, then you may have a much bigger problem in hand. It means there's a vessel that is not compliant, therefore will not stretch, therefore will only tear if something is pushed hard, and then you have a big hole that's difficult to deal with. Always puncture below the inguinal ligament and above the femoral bifurcation. Puncture in the mid vessel, both anterior and in the mid, but for both sides, both the right and the left. And then visualize all wire transactions. It's a bit like how you will, visualize your financial transactions. You want to look at every single pence, penny, rupees, paisa, ringgit, whatever it is you use. Watch every transaction carefully because it will pay the dividend. Don't mind the pun there. Don't push too hard, especially the patient complains. If the patients, and my patients are fully awake, if they complain, oh, my tummy a bit, so I stop, I look. And then when in difficulty is noticed, stop, think, and then act. Don't act, then stop, and then start thinking. And then I think the dividends will be very obvious. Thank you.
That was an excellent talk, Ganesh. I mean, I have seen so much, but I've never seen anybody use the nose cone to wiggle across tough spots until today. Fabulous, fabulous. So I'm just going to weigh in my 2 cents and then give it over to Susheel. Regarding moving the Lundquist wire, the only thing I do a little differently there is I always move it on an RCA catheter because it's such a stiff wire. So that's the only thing. I mean, of course, Ganesh is supremely experienced. Until you're really comfortable with the wire, it might be a good idea to move it on a catheter. And one more point I'd like to make is, Ganesh, don't we have to be really careful while recapturing the valve across an area, recapturing the nose cone across an area it's stuck? you could actually catch one of the paddles or part of the valve while you're doing a recapture. So it's really important before you move it back to move it forward, make sure everything is free, and then move it back. So these are the only...
The important thing is not to unsheath it past the capsule. Because if you are within the capsule, the new delivery system, the capsule is designed such a way there's about a centimeter of capsule where there's no way you're going to catch anything. Okay. But if you go past the first ledge of the capsule, then for sure you can the calcium or even a dissector plane. So that's why it's really important to do it under high fluoro settings, so you're seeing everything. If you can't see very much, if you're in a very old cath lab, then do it under cine. So you can see exactly that you have not unsheathed. The key thing is, as you're unsheathing, that you advance gently forward, so that the unsheathing process moves the nose cone forward. Mm-hmm. And when you see it moving forward, even if you're doing 1 millimeter by 1 millimeter, it's a bit like a rock climber. You climb one step at a time, and you're gently going forward. And it's amazing how 1 or 2 millimeters suddenly can significantly change your whole level playing field. And the other important thing is allowing your delivery system just to warm up a little bit. It becomes softer, more flexible, and more deliverable.
That's incredible. Loved looking at it. Susheel?
So I think it was great example, tips and tricks. I think, in terms of removing the nose cone, I think Ganesh highlighted some of the challenges, especially in angulation. You got to be very careful. I use the wire in the left ventricle to sort of push and change angulations till I can get the nose cone back safely. And I think if you're not careful, you can pop out the valve. So carefully look, use the wire in the LV, and push on the wire to get it to the outer curve and try and pull it out. There's a bunch of questions I just want to go through from participants that I probably should answer. So we talked about the shockwave. Dr. Manoj asked, why use an 014 for crossover instead of an 032 or 035? You could use an 032, but you just want to take up less lumen. And also, if you use an 014, if you take a crossover balloon over that 014, you can still inject through the wire lumen of the balloon catheter. So you put a TUI on the back end of that balloon, the wire comes out, and on the side, you can put your pressure injector and because the lumen is designed for an 032, using an 014 allows you to do angiography at the same time as having the crossover wire. Louis Fisher talked about MANTA, and I think MANTA is a step forward, but I asked about whether we need to do final angio, and I think we still do. I think even with MANTA, you need to do final angio. These are large vessels. We're taking borderline vessels sometimes. There's risk. If someone has renal dysfunction, you can do an angio with 3 cc's diluted in 10 cc's of saline with DSA. And I think you take the trade-off. I've had a bad complication with the MANTA. It's not benign for everything. And there's a cost issue, frankly. MANTA right now is more expensive than 2 percloses or more. So, from a cost perspective, it's become a challenge. And I think MANTA is good, but I think it's not, doesn't mean it levels the playing field and it's without risk. And I think you have to be careful with that. Someone asked what size sheath is needed for a coda. It will go in through a smaller sheath, but you really need a 11 or 12 to get it out easily. So I would put a 12 French sheath for a coda. And then it's Manoj again asked, can we keep a stiff wire in the pigtail in all cases so the valve system is delivered to the aortic valve? You could. I don't think you need to. I think the only thing you just got to be careful is the wires in there that you don't have clot, that you aspirate the pigtail carefully when you take the wire out if you've left it in for a long period of time.
So while you're finding Dr. Posas, the other only comment I would say is for the case I showed, what will I do next if it still doesn't go?
Yes.
Then
please.
what I would have done is taken the delivery system completely out, position a Lundquist in the left ventricle, and gone on the Lundquist wire. Now, the reason why I didn't do that first and went with where I did it was because the two complications today that I would not be able to rescue is an annular rupture or a left ventricular perforation. I think if those two happens, even in the best unit with the best surgeon in the room, depending on how big the tears are, the outcome usually is catastrophic for the patient. So I think if you have that in your head, once you have a Lundquist wire in left ventricle, It's really not supposed to be in a cath lab. It should be in some farm somewhere. But we are using the wires. And so when you're using those type of wires, it's really, really important you give it at its utmost respect the wire deserves. So
Ganesh, if I hadn't, I was holding back from asking you on air. I would have called you after this and asked you, instead of going through that painstaking release and capture, why didn't you put a Lundaquist mat and just move the catheter across?
That's right.
Okay. 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 Susheel?
No, I think we went through a lot of different topics, and I'm sorry it's a little bit chaotic with Thomas not being able to connect, but I still think I think the key points were highlighted, and I think we'll talk about alternative access next time. And I think, key is caution, get practice with smaller sheaths, don't push too hard, have the skill set available. If you don't have the skill set, have others available that can manage and rescue complications.